Okay, good afternoon, everyone, and welcome back to session 3, our third session. Hopefully you're all nice and revitalised after lunch, etc. So this is just a reminder, we'll pop this up at the end as well. This is a reminder about some feedback, please, for the masterclass today. Obviously, you'll need to, you'll have to wait for the afternoon session to do all the full feedback, presumably. But it's just if you can try and remember to do this, it really helps because we genuinely do look at the feedback every year. And if you want to tell us about things you'd like to see for next time, things that we could improve for next time, we'd be really grateful for your feedback. So do please fill this in as you go along, and I'll put it up at the end.
Just press start video before you move any.
A start video. Okay.
So I think we're going to start session 3 now. Yes, is everyone in from out the back? Hopefully. It's lovely to see you all back after your lunch break. And I'm Emma Hatfield, and I'm chairing this session with Debbie Peters, who's our fantastic endocrine nurse that helps us out. And many of you will know through communicating with her about patients. So welcome back. I hope that you found this morning as interesting and stimulating as I did. I think it's been a great session. And thanks for all the questions, both coming from the online and also from within the room. And I think this hybrid model is working really well. So let's keep that going this afternoon. Just put your hand up if you've got a question or wave or whatever. We'll try and get to you after the presentations. But to start with, we've got a fantastic speaker coming, Prof. Zaini Yen Mukhtarneh. I think I've said it correctly, but I just know you as Zani, so apologies if I didn't say that perfectly. We work together in our Pituitary MDT doing all the histology reporting of our pituitary cases, and we're thrilled that you joined our MDT, and your home base is UCL, but we're very lucky to have you as part of ICHT Pituitary MDT, and now you're going to give us a lovely talk, I'm sure, on practical guide to understanding pituitary histology. So thank you very much.
Yeah, thank you very much. And first of all, thanks, Neem, for inviting me to be here. I'll try to be quick to finish before my time so that there is time for me to answer questions you may have. And when Nemo asked me to talk about the practicalities, how we neuropathologists diagnose pituitary tumors, I thought, what should I talk about? And before I need to decide how this moves on, I thought I'll talk through the sort of starting off with the anatomy of pituitary gland, just to put in context various different diseases where they fit into the pituitary gland, and then just talk through the sort of common things I typically receive as questions or queries at multidisciplinary team meetings in relation to the tumors in the adeno or neurohypophysis, and then in relation to the non-neoplastic lesions in pituitary glands, which would be cysts and inflammatory lesions, really kind of not talking the whole through of the pituitary pathology, but really just focusing on the sort of diagnostic challenges when neuropathologists face and the sort of pitfalls one may encounter and misdiagnose. And very quickly starting with the normal anatomy of the pituitary gland. So obviously, as you all know, very basics, composed of 2 parts, the anterior pituitary gland and the posterior pituitary gland, and in between there is this intermediate part which contains these small epithelial cysts. And I'll try to see whether we can zoom in on this digital slide just to kind of very quickly talk you through the sort of very typical anatomy. Because of the internet connection, it will take a slight delay in focusing. But straight away you can see that here in this anterior pituitary gland, it's composed of these sort of lobules separated by reticulin fibers, and you can straight away see here that even without any immunohistochemical markers, one can see just purely cytologically a mixture of different cells, which if one did the immuno labeling on these cells, they would show different hormonal profiles. And then moving on here, you can see in this intermediate part, these small cysts, which are just normally, typically they're lined by very flat epithelium, and posteriorly this is how typical normal neurohypophysis looks like, which is essentially the modified CNS tissue. And then talking about the different tumors which can develop in the pituitary gland, metastatic tumors, lymphomas, germ cell tumors, they sort of are misplacing the anterior and posterior pituitary tissue and can develop, and then therefore very difficult to, at histological level, say specifically where they're developing. In the posterior pituitary tissue, those would be the pituitary-cytomas, and in the anterior pituitary tissue would be the craniopharyngiomas, including the intermediate part and the pituitary adenomas. But then not infrequently, we obviously also encounter other CNS, cranial nerve, leptomeningeo derived tumors such as optic nerve gliomas or meningiomas. And as I mentioned before, I'm not going to talk about every single entity, just focusing on those where there can be some diagnostic challenges or pitfalls in relation to the diagnosis. And for that, starting with the pituitary-cytomas. So obviously the pituitary-cytomas develop from the posterior parts of the pituitary gland, the neurohypophysis. And in principle, you might have encountered in your careers these three different entities: pituitary-cytoma, granule cell tumor of the cellular region, and the spindle cell oncocytoma, where the distinction is purely morphological, depending how the tumor looks like, whether it looks most closely similar to the normal posterior pituitary tissue, or they have this very oncocytic cytoplasm, or the morphology is more spindle shaped. But the important thing which we have learned over the last decade is that they all are derived from most likely the same cell type, which is thyroid transcription factor expressing posterior pituitary cell type. So therefore, we really now consider them being a spectrum of single nosological entity, and we no longer consider these three diagnoses as different entities, but we actually consider them as subtypes of the same entity. And therefore, from now on, it most likely you will only see one single diagnosis called pituitary-cytoma, where these histological appearances, where there is sort of this granular cytoplasm, granular appearing cytoplasm, or the spindle appearing cytoplasm will simply be described in the microscopic description, given that they develop from the same cell of origin, and there is no clear indication that they would ever respond to differently to any treatment or have any different prognosis. The next one I really would like to touch upon is on the craniopharyngiomas. And in terms of the craniopharyngiomas, again, we are now very clearly distinguishing adamantinomatous craniopharyngioma from papillary craniopharyngioma. And the reason for that is that they both are derived they are derived due to very different genetic mutations. So adamantinomatous craniopharyngioma is characterized by beta-catenin mutation, and the papillary craniopharyngioma is characterized by B-rho-V600E mutation. So again, these are no longer considered sort of subtypes from the same tumor entity, but actually completely different tumor entities, completely different tumor types. So, and in terms of the diagnosis, to save the time, I'm not going to go on these digital links, but these slides can be very happy to be shared, and then you can browse through the digital slides yourselves. So in terms of the diagnosis, the adamantinomatous craniopharyngioma, there are two diagnostic hallmarks. Therefore, we do not frequently test for the beta-catenin mutation. And these diagnostic hallmarks, why we do not frequently need to test for the beta-catenin mutation, is this so-called wet keratin, which is essentially dead epithelium arranged in these small globules and has a very specific characteristic histological appearance. And that the epithelium pattern has this very prominent sort of very peculiar stellate appearance. We call it stellate reticulum. And because of these two diagnostic hallmarks being absolutely pathognomonic for adamantinomatous craniopharyngioma, beta-catenin mutation is not usually tested, although one could easily sequence the beta-catenin gene to identify the mutation. The papillary craniopharyngioma by default should not have wet keratin or stellate reticulum, would otherwise have this sort of a papillary squamous epithelium configuration, and by default should harbor BRAF-V600E mutation. And because this kind of appearance can also rarely be seen, and I'll talk about it later on in greater detail, in a very small proportion of Radke's cleft cyst. So here it's mandatory that we test for BRAF-V600E mutation. There is a mutation-specific antibody available, and you can see it here being stained for, which one can easily do in any laboratory. And if it shows the cytoplasmic mutation labeling, that means there is BRAF-V600E mutation. If the antibody is not available or technically difficult to interpret, it's very easy to do the BRAF gene test sequencing and then look for the V600E mutation. And this should be done as a routine anytime one suggests papillary craniopharyngioma. One of the reasons also being that, of course, BRAF-V600E mutations, there are it's a druggable target. There are BRAF-V600E inhibitors, which in theory, these patients could be treated with if clinically appropriate. Then moving on into pituitary adenomas, and here are the two things I wanted to touch upon. One is in relation to the nomenclature, and the other one how we diagnose the pituitary adenomas based on their transcription factor expression profile. So one important thing is that there is a sort of a huge ongoing fight between European and American pathologists on the best classification of pituitary adenomas. And right now, it's because this agreement cannot be achieved. This entity is diagnosed through this slash as pituitary neuroendocrine tumor / pituitary adenoma, for the reason being that historically it's of course been called as pituitary adenoma, but then the suggestion mainly from the United States pathologist is that that's not an appropriate term for this tumor, because first of all, adenoma is something which is always by default benign, which pituitary neuroendocrine tumors are not always necessarily completely benign. And second of all, adenoma is something which never metastasizes, which again is not entirely correct for pituitary neuroendocrine tumors. And thirdly, because adenoma is something which technically develops from glandular epithelial tissue. And again, that's not how we consider adenohypophysis tissue. They consider it to be neuroendocrine epithelial cells rather than gland-forming epithelial cells. So for that reason, and because the United States pathologists cannot really convince the European pathologists that for time being, this entity is having these two words. I know that there are certain endocrinologists who say that patients find it quite concerning to receive the diagnosis pituitary neuroendocrine tumor, that patients apparently would prefer the diagnosis pituitary adenoma. But yeah, arguably that also is purely semantics here. And then in terms of the transcription factors, that's a very important thing, how we nowadays diagnose pituitary adenomas. We diagnose them based on the lineage, based on what transcription factor the tumor expresses. So in a normal anterior pituitary gland, there is a mixture of these lineages, the SF1, T-PIT, and PIT1 lineages. So SF1 being the gonadotrope, T-PIT1 being the corticotrope, and PIT1 being the growth hormone prolactin TSH lineage. And in the pituitary adenomas, it's typically one lineage which proliferates, with few exceptions, which we're gonna touch upon a little bit later on. And the only key thing here, purely when you are reading pathology reports and when there is a mention of these transcription factors, is to just be aware that as every other transcription factor, we were talking about OCT3 for in one of the presentations, the transcription factor by default needs to show a nuclear labeling. So if the description describes that there is whatever transcription factor expressed in the cytoplasm, then something is wrong, technically wrong with the staining, and that's not interpretable. And one cannot therefore assign a certain lineage on something which shows cytoplasmic labeling. So it needs to be in the nucleus to consider that staining appropriate. And if we do not know with which transcription factor we have stained the tissue for, there is no way purely looking at this slide, we would be able to say whether it's a gonadotrope, corticotrope, or PIT1 lineage. So the outcome staining would look identical. So one needs to know what's been stained for. And then now talking about very specific examples where typically I receive queries from various different multidisciplinary team meetings in relation to differential diagnosis of various PITNETs. One is in relation to mammosomatotrope versus mixed lactotrope and somatotrope adenomas. How do we know which one it is, and can we actually tell apart? So of course, first of all, they are both PIT1 lineage tumors. And the difference is that mammosomatotrope has both hormones, growth hormone and prolactin, expressed by the same cell, whilst the mixed lactotrope and somatotrope, those hormones are expressed by different cells. And as mentioned, they, of course, by default has to be PIT1 immunoreactive in the cell nucleus. And the thing is that actually diagnostically, it is quite a challenge and many times impossible to actually tell apart whether it's mammosomatotrope, meaning that it's expressed by the same cell, or it is actually a mixed dual expression by different cell types of prolactin and growth hormone. And the reason being the following. So if you have a diffuse growth, as an example, growth hormone expression across every single tumor cell as in this example, and then you have random cells also showing prolactin expression, you are obviously absolutely sure that it has to be mammosomatotrope because every single cell is expressing growth hormone. So therefore, there is no way these are separate cells which are expressing prolactin. So those instances are easy to say that it's mammosomatotrope pituitary adenoma. However, instances which are not infrequent, which look like this, where a proportion of cells are expressing growth hormone and a proportion smaller or larger are expressing prolactin, because these are consecutive sections, each cell is approximately 8 microns thick and the section is 5 micron thick, it's nearly impossible for us to be able to overlay and correlate and say whether this cell expressing prolactin is by any chance any of these cells which are expressing growth hormone. So in those instances, it is literally impossible with kind of routine diagnostic means to differentiate between mammosomatotrope and mixed lactotrope and somatotrope. Of course, at the research level, one could do a dual labeling, and then that will be an easily answered question, but we do not do that routinely. Moving on, the next one is in relation to the diagnostics of so-called prolactinomas. So from the pathology point of view, there are at least three different types of so-called clinically called prolactinomas. One we call sparsely granulated, and those are the prolactin expressing adenomas. First of all, which are only prolactin expressing adenomas, where the prolactin has this very specific perinuclear labeling in the Golgi apparatus. And the other one is, which is much rarer, densely granulated, where one sees diffuse cytoplasmic prolactin expression. So sparsely or densely in prolactin expressing tumors is based on the prolactin expression in the tumor. And the correlations are that the sparsely granulated ones typically are those which are well responsive to dopamine agonist therapy, and the densely granulated ones, which typically are resistant to dopamine agonist therapy, and therefore also are the ones which we usually receive for examination on the histological level, and where we also therefore can see the treatment effect. So these dystrophic calcification, fibrosis, which are sort of histological hallmarks that the tumor has been already treated prior the surgery. And also in these instances, which also correlates with this resistance to the dopamine agonist therapy, usually these densely granulated prolactin producing adenomas also have much higher proliferation indices. The other thing to note that these sparsely granulated ones, which typically are well responsive to dopamine agonist therapy, they still are more aggressive in men than in women. So the third type of prolactin expressing adenoma is in this group of PIT1 lineage, of course, where there are other PIT1 lineage hormones expressed, such as TSH or growth hormone, and the one where the prolactin would dominate and therefore would be the kind of most in the differential between the sparsely and densely granulated prolactinomas is this acidophilic stem cell pituitary adenoma. But the reason how we can with confidence say it's acidophilic stem cell is if we see diffuse prolactin expression as we see in densely granulated prolactinoma. But on top of that, we also have a little bit of growth hormone expression, but no TSH expression. And then in terms of these plurihormonals, there are also so-called mature and immature pituitary adenomas, where the difference again is that mature ones have a widespread diffuse growth hormone expression and a little bit of prolactin and TSH expression, and the immature shows the PIT1 lineage, so PIT1 nuclear expression, but there is just occasional growth hormone, prolactin, TSH expression, kind of similar what you see in this picture here. So this can't be a pure TSH producing PIT1 lineage adenoma, because there is unequivocal growth hormone and prolactin expression as well, but it cannot be either the mature or acidophilic stem cell, because the growth hormone for the mature is too little and prolactin for the acidophilic stem cell is too little. So that's how we differentiate those. Now the second or the third typical question is in relation to this Crooks-Hyland change. What does that mean and how that helps us for the diagnostic purposes? So first of all, Crooks-Hyland change was described by a gentleman called Crooks, who worked in a very famous neuropathologist lab in Royal London. The original paper only contains his name, doesn't contain her name, although she was the senior person in the lab. But that's obviously how it was in those days. And Crooks-Hyland change refers to this very specific cytokeratin labeling in the cells, so that the cytokeratin labeling is pushed only to the periphery, so it doesn't show diffuse cytoplasmic labeling, because in between this blue nucleus and this periphery of the cell, there is an amorphous hyaline material deposition. And Crooks-Hyland change as such, we see in a normal gland. When we talk about Crooks adenoma, then we see identical labeling pattern. So this cytokeratin labeling is pushed to the periphery because of this hyaline material deposition in the cytoplasm. But instead of seeing that in a normal gland, we see it in ACTH, T-PIT lineage pituitary adenoma. And in those instances, we refer to as Crooks adenoma, which from all the ACTH producing adenomas is supposed to be the most aggressive one. But here are a few caveats, is that if one sees Crooks-Hyland change in the normal anterior gland, it tells that there is a hypercortisol, so there is excess of cortisol in the patient's body, not necessarily in pituitary gland, but there is excess of cortisol production. But the important thing to remember is that if there is no evidence of Crooks-Hyland change in the normal gland, it does not by any means exclude hypercortisolism. And there are a number of reasons for that. First of all, there is a possibility that the included normal anterior pituitary gland next to the tumor is just so scanty, so that it was simply not represented in what's included in next to that gland. But also we know very well that in these two occasions, so silent sparsely granulated ACTH expressing pituitary adenoma and primary corticotrophic hyperplasia, for whatever reason, they tend not to induce Crooks-Hyland change in the normal anterior gland. And then talking further about the T-PIT lineage ACTH producing pituitary adenomas, again, we distinguish these two types, densely and sparsely granulated, where here, in contrast to prolactin expressing adenomas, the distinction between densely and sparsely granulated is not based on ACTH expression, but is based on the cytokeratin expression. So if one sees diffuse strong cytokeratin expression, that is densely granulated type, and those are usually the ones which are the microadenomas, very small with very florid clinical manifestations. And the sparsely granulated ones are where there is sort of a patchy cytokeratin expression, and these are the ones which typically are larger. And if the tumor turns out to be silent, then usually these are the sparsely granulated ones. And that leads me to the question, what is the significance of hormone expression in a given pituitary adenoma? So for the PIT1 lineage, so that is growth hormone prolactin TSH, prolactin, extent of prolactin expression has an important significance, because the ones which show diffuse prolactin expression, those are the densely granulated and tend to be the ones which are non-responsive to medical treatment and generally with a much higher proliferation fraction. For growth hormone and TSH, that's not the case. So for growth hormone, it's not the growth hormone expression which we take into account to divide into sparsely or densely granulated. It's the cytokeratin, and growth hormone expression intensity or extent does not really correlate. For ACTH, as I just discussed, there is no known significance. It's again the cytokeratin pattern which helps us to predict how aggressive the tumor will be. And for S1 lineage, which would be the gonadotrope with FSH and LH expression, again, there is no reported clinical significance in relation to how much FSH or LH is expressed by the tumor cells, how much it correlates with the hypogonadism. And the next question I wanted to address is about the mitotic activity or proliferation fraction, which is still kind of a very sort of unclear territory after decades and decades of diagnosing pituitary adenomas, where the bottom line really is, so kind of many textbooks use 3% as a cutoff, which most likely is not really the right cutoff to be used. What is known that if the tumor has proliferation fraction over 10%, then those are typically clinically quite aggressive, but those which are with very low proliferation fraction, if they happen to be with Crookes-Hylin change, which with Crookes-Hylin change, which not infrequently happen, they can still show aggressive biological behavior. And then this gray area between the 3%, 5%, in all honesty, there is a very, very poor correlation with the actual clinical outcome. So with the bottom line being, if the proliferation fraction is really high, over 10%, that's a very worrying sign. But everything below, it really can go in, it really can behave either way. And then there are a few instances with aberrant transcription factor expression. One would be where there is no transcription factor expression, but there is, let's say, gonadotrope, FSH or LH hormone expression or any other. Then the chances are high that the transcription factors, they're just more sensitive for to the technical preparation damage, various alcohols and paraffin. So in those instances, which we not frequently encounter, it's most likely technical problem while the transcription expression appears to be not there. So we, in those instances, go by the hormone expression. And the other rare, but we encounter occasionally instances where there's no transcription factor and no anterior pituitary hormone expression, which are those true null cell pituitary adenomas, where the only important thing is to make absolutely sure that it's by no chance a metastasis from a different neuroendocrine tumor located somewhere else in the body. And then the second option is when there is dual or multiple transcription factor expression, where really the main diagnostic challenge is to decide whether this additional transcription factor cell presence, whether they are just entrapped native cells, which again can occasionally obviously occur, or if it's a genuine true dual or multi-lineage pituitary adenoma. And there are instances where again that is simply unsolvable, where it's just impossible really to be sure whether those are entrapped native cells or it's a genuine multi-lineage pituitary adenoma. Moving on about the cysts. So arachnoid cysts, we find it quite easily to be diagnosed histologically because they have very specific immunoprofile. And in principle, also Radke's-Cleft cysts in over 90% of cases, very easy to diagnose, again, because of very specific immunoprofile. The complicating occasions are when the Radke's-Cleft cyst is undergoing very prominent squamous metaplasia. And when that happens, then the main differential diagnosis is between Radke's-Cleft cyst with extensive squamous metaplasia or papillary craniopharyngioma. And nowadays, the presence of BRAF-V6 mutation is obviously a mandatory test. And if the lesion shows BRAF-V600E mutation, then it's a definite confirmation that it's papillary craniopharyngioma. It's more problematic when there is no presence of BRAF-V600E mutation, because this mutation is reported over 95% of papillary craniopharyngiomas, but not in 100% of papillary craniopharyngiomas. So then it kind of still remains open, and one needs to follow up the patient to find out whether it's Radke's-Cleft cyst or actually papillary craniopharyngioma without BRAF-V600E mutation. And in terms of the inflammatory cell presence in pituitary gland, there are few instances which, again, technically, from the pathology point of view, can be a little bit challenging to diagnose. So a typical lymphocytic hypophysitis is very rich in T cells, so very florid T cell infiltration. So arguably, one would think, what's there problematic to diagnose, because there are exceptionally rare lymphomas which are T cell lymphomas. Majority of the lymphomas ever reported in pituitary gland are B-cell lymphomas. The third possibility is IgG4 disease, which typically is rich in plasma cells. And if we see a plasma cell rich infiltrate in pituitary gland, then we would do the IgG-IgG4 disease, IgG-IgG4 ratio to decide whether it would be compatible with IgG4 disease. But in relation to the differential diagnosis of lymphocytic hypophysitis, the problem really is, as in also the previous case one of you presented, demonstrated, is that it's a common thing that in germinomas, there can be a very florid reactive inflammatory cell infiltrate, which is always rich in T cells. And then if the biopsy is very small, it's not unknown that this biopsy only contains the T cell rich infiltrate and no neoplastic cells at all, or the neoplastic cells, as in this example, are not necessarily easily visible. So here, amongst this very florid T cell rich infiltrate, there are these large, ugly looking cells. If one does the right immunopanel, would be identifiable as OCT3 positive, so therefore germinoma. But that's where the sort of differential diagnosis and misdiagnosis can be for an actual germinoma, as lymphocytic hypophysitis. And as a last kind of a pitfall diagnostic challenge, I would like to talk about gliomas, which not infrequently in relation to optic nerve, one can be in the differential diagnosis. So here I just wanted to highlight that reactive gliosis histologically looks identical to pilocytic astrocytoma, so low-grade glioma. An example is here, so if there's a radiologist in the audience, they would be able to talk more about a lesion located in this region. But if the biopsy is taken from this lesion and the appearances are like this, so you have gliotic tissue here. Pilocytic astrocytomas are characterized by something called Rosenthal fibers, and here all these pink structures, those are many Rosenthal fibers. The second histological hallmark is that it has this biphasic appearance that in some areas it looks sort of this loosely textured, and in other areas it's more cellular. One could easily, based on this biopsy appearance, diagnose this as pilocytic astrocytoma. However, as I say, reactive gliosis has very similar, if not identical, appearances to low-grade glioma. And actually, in this instance, this is not a pilocytic astrocytoma. It's very florid reactive gliosis next to adamantinomatous craniopharyngioma. Again, was this just to highlighting that one should never really take pathology pathology diagnosis as a kind of, that has to be that. So if it doesn't fit into the radiology context, which I understand this doesn't, and doesn't fit into the clinical picture, then there is a high possibility that the pathologist just got it wrong, not because they don't know, but because there are certain things which can look identical to each other, as this example. And again, if the question would remain that this really cannot be pilocytic astrocytoma, we have molecular tests nowadays which we can do on this sample, which all would come back negative, telling there is no pilocytic astrocytoma characteristic mutation or fusion in this tumor, indicating that it has to be gliosis next to a lesion which is not included in the biopsy. And on this note, I think I'll stop here, but very happy to take any questions or clarify further if something was not clear.
Thank you very, very much. I found that very informative and comprehensive. I think we maybe will weave in any questions to our cases because we're just running over. Do you want to take one or two questions on the chat?
Don't mind, it's fine.
Yeah,
Perfect. Just a quick one here. Great presentation, thank you. I recently had a patient with acromegaly who stained for TSH on histology. How is this possible?
A TSH histology.
TSH staining in acromegaly.
Yeah, so it's very, very plausible, and it's really hidden in this slide. The answer to the question is hidden in this slide. So from the description, it is of course Pit1 lineage, growth hormone, acromegaly, and TSH are from the same lineage. So it has to be plurihormonal pituitary adenoma, where the patient histologically the most prominent hormone is TSH, but actually there is also growth hormone and maybe even prolactin expression.
Amazing, thank you.
Jeremy Cox got a question for you.
We've always been worried about silent corticotroph adenomas. Can you just confirm to us which category they go in? So they're TPIT positive and they're densely granulated, are they?
No, so yeah, silent corticotroph pituitary adenomas in most instances are sparsely granulated, meaning that they have variable ACTH, variable cytokeratin expression. There is this thing about the silent corticotroph pituitary adenomas that different people have different cutoffs, what they call silent. Is it silent clinically or also silent biochemically? Yeah, but yeah, so it would be sparsely granulated.
And can I just quickly ask about Cook's hyaline change? Because this is an issue when we have patients who may or may not have Cushing's, and they may have been given steroids in the past. And so that makes it, I think, is it difficult to then say whether it's, if you take, say, steroids for some time, do you know how long it takes if you take steroids exogenously for you to become Cook's hyaline positive?
Yeah, so steroids can disrupt the appearance. I can't say really how many weeks or so. Usually for lymphomas, it's just obviously a different picture, but usually it's around 3 weeks to 3-4 weeks, okay, which makes a difference.
But because we have patients who put on replacement steroids and then they have surgery maybe some months later, and then of course it might be Cook's hyaline positive and yet they're a non-functioning adenoma. And then everyone goes, oh, is it possible that this was Cushing's in this slightly overweight patient who's slightly hypertensive?
Yeah.
Okay, thank you. I think that's something we grapple with, Kareem, definitely. And is there anything simple to take away about what causes the cytokeratin to be going out to the periphery? I mean, just you've described it can be normal when someone's got excess exogenous steroids in their system, or it is found in the pituitary ACTH adenoma. And is there some it's a descriptive thing, but I just wondered why.
I mean, using electron microscopy studies, all people have seen in past is this amorphous hyaline material. What exactly is that amorphous hyaline is not yet fully characterized. The suspicion is it's still keratin filament derived, but yeah, what exactly it's made of, I'm not sure it's known.
Okay, thank you.
There's one other question in the chat I want to ask, which is, we know Cas7 often does not correlate with regrowth. Are there any newer markers?
No, sadly not. Sadly not. It looks like that the next step, hopefully even next year, we will start using more genetics to characterize the pituitary adenomas. We know for cortical adenomas, they use USP8 mutation seen in a small proportion of cases, which is associated with particularly aggressive kind of biological behavior. So yeah, so there is another marker which is also kind of genetic called P27, which can differentiate better the densely granulated from silent sparsely granulated pituitary adenomas. So yeah, genetics will be, when it's incorporated in routine, which will help more than any of these histological parameters.
Thank you so much. That was fantastic. And now we'll go on to our case presentations.
So I'd like to welcome Dr. El Abdi with her presentation of IgG4 hypophysitis and thyroid abnormalities.
Hello everyone, good afternoon. My name is Suha. I'm with 6th grade NIE. Thank you for giving me this opportunity to present an interesting case on behalf of my team. And my case today is about a 60-year-old lady. She had recent COVID infection. She called her GP complaining of headache. Her headache was for 3 weeks, gradually worse over the first 3 days. It was frontal, pounding, and worse when she's lying down or bending forward. She tried aspirin, paracetamol, and codeine, but that didn't help. After 3 days, her headache eased and became dull and achy. Her past medical history included psoriasis and anxiety, asthma, for which she taken steroid inhalers and venlafaxine. The GP referred her to rheumatology and optician. On optician exam, there is no abnormality found, and the rheumatology referral was done because of query GCA, because of high ASR of 33, C-reactive protein of 17. Rheumatology were not convinced, so they discharged her, go have some ibuprofen, some safety netting, and come to the ED if you still have headache. The headache continues, and she presented to AMU. And because of the recent headache of recent COVID, she had MRI and she had MRV to rule out the cavernous sinus thrombosis. And as usual with endocrine, MRI had showed pituitary lesion. And AMU go ahead and ask for pituitary profile, showing prolactin of 889, which we know it is a bit high. LH, FSH is normal, but definitely they are appropriately normal for a postmenopausal woman. Her cortisol was 168, her TSH 0.42. Unfortunately, I couldn't get the FT4 level. However, they contacted the endocrine, and the endocrine team advised starting her on hydrocortisone and levothyroxine. So she was started on hydrocortisone stress dose initially, 20-10-10, and a low dose of levothyroxine, 50. Endocrine as well booked her for short synaptin test and requested MRI pituitary. And this is the T1, and you can see that the pituitary is a bit enlarged, and you can see it contacting the optic chiasm, and this is T2. And the report came with 10 millimeter focus on the right side, crossing the midline. There is no evidence of hemorrhage, and there is contact with the optic chiasm. However, there is no associated compression. As we expect, the cella is mildly expanded. She came to the endocrine clinic, and the headache significantly improved. A Schwarzenegger test showed a flat baseline as 25 and a flat response at 102. Again, prolactin was mildly high. LH-FSH is low for postmenopausal women. Estradiol is very low. TSH 0.79 and FT4 is still low, and levothyroxine 50 microgram. So levothyroxine was increased to 75, and hydrocortisone was continued, and we asked her to do another thyroid function in 6 weeks and follow up after 3 or 4 months. This would have been a regular case where we follow up a non-functional pituitary adenoma. However, a turn came in, and she called us complaining that the headache got worse. And she thought there is some left eye changes. So that time, in February 2022, she was advised to come to endocrine clinic. And she was examined in the endocrine clinic after a few days. And the colleague who saw her thought she has left partial defect, query quadrantenobia. The MRI requested urgent, and optic visual field exam requested as well. And this is the MRI pituitary. And this is T1, and you could see that the pituitary lesion got larger. And you could see there is change in the signal. And that is what was reported. So they reported a new hemorrhage. They reported increase in the compression on already stretched optic chiasm and increase in the size by 6 millimeter. And abutment of the cavernous sinus as well. The perimetry showed quadrantenobia again, left upper side. And so she was referred to neurosurgery in Southampton. She had her transsphenoidal surgery in April. And out of surprise, we have a pathology report showing IgG for hypophysitis. The patient was continued in hydrocortisone. However, my question here, can we have the multimeter?
You can leave them out and I'll
the question here is what you would do. Would you continue the hydrocortisone and do synactin test? Would you do further investigations? Or would you switch her to prednisolone? Or would you consider other treatment for IgG4 disease? Yeah.
How much hydrocortisone is she on? Sorry.
She was finally on 10.55.
I was going to say, I think there's been a postprandial slump a bit, actually.
So the number to register again on menti.com is at the top, 68078445, if anyone's logged off, and just give a quick immediate
And while you're
response.
doing that, there's a question here that says, was there any radiology that suggested IgG4 with hindsight, looking at those pictures?
Maybe we could do that at the end.
Yeah.
Should we go back to the slide? Yeah.
We've got some answers.
That might be a healthy done. We're nearly at 50. Should we have a look?
Okay.
Oh, goodness, that's a very mixed bag, isn't it?
Yes, that is a bit. So.
Quite a spread indeed. And steroids win by the look of things, don't they? Generally, sorry. So steroids win, I think, in terms of either hydrocortisone. No, it's wrong. Sorry. No. Oh. Thank you.
There is no right or wrong answer here. we opted to continue hydrocortisone. Some people mentioned something about prednisolone, and I think this is one of the questions and one of the maybe opinion I would like to hear about. We didn't do synactin test because a trial to stop her night dose resulted in a cortisol again 13 early morning. We didn't switch to prednisolone. Definitely, we didn't consider steroid sparing treatment. Our MDT concluded, let us do a CT CAP, let us do IgG4, repeat MRI, pituitary in 3 months, and refer her to renal team. And this is the CT CAP done in June 2023. And it was unremarkable, a part of some cystic fatty lesion in her adnexial, right adnexial component. It is 9/11, so it was big, compressing the right ureter and causing hydronephrosis. And the CT suggested this is dermoid cyst, basically. IgG4 was completely normal, 0.57, and renal team discharged her and advised refer her to rheumatology. And rheumatology again done all the autoimmune screen and they discharged her saying there is no systemic involvement. Gynae and urology team did the surgery for the adnexial mass and it was documented as teratoma. And yes, she will be followed up in the endocrine clinic. So in July 2022, you might forget all the dates, but I'm going to put them on a timeline later on. So in July 2022, she was on levothyroxine 75. Her FT4 is 24, and the normal is 22, and FT3 is 7.3, and the normal in our lab is 6.9. So her next follow-up was in January this year, and now FT4 is 41, FT3 is 16.8, but she's now symptomatic. She's having palpitation, sweating, and heat intolerance. So levothyroxine was stopped. After stopping levothyroxine for 2 to 3 weeks, she came with almost same numbers and overt hyperthyroidism. Now the decision, shall we start the carbimazole? And we did. We started the carbimazole 20 milligram daily, propranolol because she was symptomatic. And we sent for TRAB, TSH receptor antibody, and TPO. In March, we can see that FT4 is 19.9 and FT3 was 5. And we can see in April, it's still normal. TPO was 153. And you can see the upper limit is 49. TSH receptor antibodies came 1.6, which is positive. Not double normal, but positive. July again, the lady presented her for her regular follow-up. But this time, she presented with a profound hypothyroidism, undetectable FT4, undetectable FT3. Feeling very tired, carbimazole stopped, and because of these numbers, she was immediately started on levothyroxine 50. In August, September, her FT4 quite normal, and she is still in levothyroxine 50 microgram. The booklet mentioned she's off medication, and I need to correct that. She's still on levothyroxine 50 microgram. MRI pituitary repeated twice after surgery and showed post-operative appearance, and there is no cystic recurrence and just residual pituitary gland tissue. I would go for the timeline. I would say that the transsphenoidal surgery done in April, in July, she was mildly hyperthyroidism on levothyroxine. However, hyperthyroidism was overt in February, and again in 5 months, she went to profound hypothyroidism on antithyroidal medication. So this is my case. And my next question is, do you think this is Graves? Do you think this is Hashimoto thyroiditis or IgG4 related thyroiditis?
Right, come on, everyone. Lots of votes, okay? Lots of votes.
Okay, so most of you have gone for an IgG4 related thyroiditis. So let's have a look at a bit more of the case.
Something we diagnose every day.
Yes.
I don't have an answer. We thought this is Graves because the TSH receptor antibody is positive. But the lady in the clinic on levothyroxine and she's stable. And because of that, I get the case here because we don't have an answer. Apparently in 4 or 5 months, we couldn't manage to do any scan for her. These are a few bits about the IgG4 related disease. It's multisystemic and it's not always associated, the hypophysitis is usually associated with other organs. It is less than 5% of the cases. And usually it is multisystemic. It comes with multisystemic disease in up to 90 cases. And I've never heard about criteria to diagnose IgG4, and it was educating for me to know that there are some suggested criteria since 2011. But pituitary histopathology is only single criteria to diagnose this. So my questions, as isolated IgG for we treated her with hydrocortisone. Do you think that we should have treated her differently? Prednisolone or high dose prednisolone? And how often we should do MRI pituitary? And do we need to do a systemic surveillance considering this is multisystemic disease? The other bits of question about the thyroid. What type of thyroid she has? And if we think this is riddles, she has no hard goiter. Do we need this biopsy, and would that change the management?
Thank you very much.
Thank you for that super presentation. Do we have any?
We might get the imaging looked at.
Yeah, we'll get your imaging slides up for a second. Emma, would you mind? I'm sorry. It's only because it's so lovely to have an expert, that's why. Would you mind just, if you just put up the original MRIs that you had?
This is the first
That's
one.
perfect. That's all that we'll take. It's fine. Can you just let us know your thoughts, if that's all right? We've also got the histology here.
Yeah, thank you. Did you have a post-contrast as well,
I think just T2,
Yeah,
I think.
she had T2.
it's the T1 and the T2? Okay. So in general, these features are not in keeping with the classical IgG4 hypophysitis. I wouldn't have expected anyone to suggest that in the first instance. So firstly, you can see that we've got this mass classically in IgG4 related hypophysitis. It can be T2 hypointense. It's not specific, can be seen in other granulomatous processes or sarcoidosis or even sort of burnt out lymphocytic hypophysitis. So that's not typical. Also, these cystic areas are also not typical. It looks more mass-like. In hypophysitis, the cell is not typically expanded, which again is this would be slightly unusual. If we had post-contrast imaging, it's also typically avidly enhancing, as I mentioned earlier, and there's also usually involvement of the stalk, although there doesn't have to be if it's primarily hypophysitis rather than an infundibular neurohypophysitis or a panhypophysitis. So generally speaking, this looks more like an adenoma, to be honest. It looks like a macroadenoma. It looks like a mass-like lesion with intrinsic T2 hyper to ISO intensity within an enlarged cella, and I'm assuming that there would be some heterogeneous enhancement and there's no visible enlargement of the stalk. So also just to note that on this particular image, there are no supplementary features of IgG4 related disease, such as hypertrophic pachymeningitis, where you can see T2 hypointense thickening of the dura, for example. It could be anywhere, including over the convexities. You could also get orbital involvement, such as extraocular muscles, or the lacrimal glands, or the infraorbital nerves as well. And also parotid gland disease. So all in all, there's really nothing on this particular scan to suggest IgG4 related disease.
Thank you, that was fantastic. Thank you, Emma. Any comments from the floor or online?
There are some online here. So, I mean, first of all, statistic Graves is more common than IG4 by quite a long way, obviously. And the question really is, because you've got biopsy proven IgG4, would it be worth biopsying the thyroid as well? Question mark.
Yeah, this is my question. Well,
followed by.
Can I just ask, Zani, is there any chance that I thought I'm struck by the imaging not collaborating with the histology? Is there any chance of you revisiting the histology? Although I take the history being quite suggestive, but could that? I'm trying to think round the problem back to front.
Bit, Emma, were you thinking about headache potentially getting a bit better with steroids? Was that the sort of thing you were thinking about, hypophysitis?
Bleeds into adenomas, and I'm hearing down the telephone what I'm hearing is an adenoma, not a diffuse inflammatory lesion.
And just a few things from the pathology point of view. So it is slightly concerning that the serum levels are within the normal range. Again, I also would be very curious to see the pathology report, although I know people, and especially because I know people in Southampton very well, and just generally us and Southampton people, it's exceptionally rare we say with confidence that it's IgG4 disease. I can't recall an instance where we would have said absolutely confidently this is. I can recall a single instance where there was proper pachymeningeal thickening, fibrosis, and a single instance where we have said this is a definite IgG4 disease. Usually the reports are way more descriptive that one needs to correlate with serum IgG4 levels and so forth. So I'm just very surprised to hear that there was such a definite diagnosis of IgG4 disease, and with no kind of further discussion, especially given that the serum IgG4 levels are within the normal range.
So I haven't looked at the pathology, to be honest. Because the pathology is done in Southampton, so it's a correspondence. This is IG4. And we knew the MDT done, and this is a CT CAB, IgG. So IgG4 level came later on. And I
would be worried that there's a little bit, something's gone lost in translation, just because usually pathologists do not give a very straight, like kind of a definite IgG4 disease diagnosis.
It might be worth revisiting the histology.
I know. I don't know if Florian's got anything you want to say, because I know we've had a series with IgG4, and he does tend to follow through our interesting pituitary patients with that.
Thank you. Thank you. I would agree with our radiologist that the radiology doesn't really suggest IgG4 disease. It doesn't suggest hypophysitis, actually. And it would also be unusual, please correct me if I'm wrong, to see a bleed in that scenario. So we've never seen that with our hypophysitis cases. And I also would agree with Sani that the histopathology is often, it's not very certain, it's often a clinical context. Although I have to say, with all those cases I've seen with isolated IgG4 pituitary disease, the IgG4 serum levels are almost never elevated unless there's another organ involved. And the thyroid, yes, to me it looks like a thyroiditis, isn't it? Because I mean, it's not Graves, because you get secondary hypothyroidism afterwards, which is probably a result of the pituitary bleed and the panhypopituitarism. There was a transient thyroiditis that would explain that presentation, possibly. Yeah, I would also revisit the histopathology, because if we have got a suspicion that it is hypophysitis, actually for hypophysitis, then there is a higher risk of recurrence. And you may have to review your surveillance strategy, and other treatment may be required, but I very much doubt it.
Thank you. Grim, is there anything on the chat? Sorry. Any other
Sometimes physical
questions?
notes helped. It says in hyperphysitis, it looks and feels different to an adenoma. I think for certain I've got when they operated, if they noticed a difference in the appearance.
I'm not sure to be
But
honest.
that's a good point too.
Jeremy Cox has it. Oh, I'm so sorry. Now the other side.
I'm just interested by the right-sided hydronephrosis. Do you think that correlates?
This is dermoid cyst, and it was removed. Dermoid cyst on the CT, and it was removed. Despite this, her creatinine and GFR is normal. It was removed, and the pathology came as teratoma.
And hydronephrosis resolved.
Yeah.
Yes,
Yeah, but the
Florence point.
creatinine is normal, and the GFR is normal.
So Florence point, just for I'm just conscious of people online, is retroperitoneal fibrosis associated with IgG4 disease?
So I think in summary, revisit the histology, but if it is IgG4, it will definitely need more follow-up and surveillance, and actually treatments might be steroid-sparing agents if it recurs and respond to that. So there is a whole pathway, you're absolutely right, to flag. It was just because we were slightly thrown by the appearance, but never say never, we wanted to revisit the whole diagnosis. And then it could be a thyroiditis in that pattern of it going up and then down, which could be any of the etiologies, I guess. And my final question, was there anything else to push you towards Graves? Although I agree it didn't behave like that. We always look for eye signs. Now, a fascinating case. Is there any last question before we move on? Because I'm conscious we're running over now.
Thank you. Yeah.
It's fascinating. We'd like an update, please.
I will let my consultant know.
Thank you.
Thank you.
Shall I present, or do you want to? Okay. So we'll go on to our next case. Thank you very much. Aseptic meningitis due to craniopharyngioma with Dr. Smart. Thank you very much.
Hello, my name is Vera. I'm one of the registrars at Royal Surrey, and we wanted to share this case with you today because it was quite an interesting case with unusual presentation, which gave us a bit of a diagnostic challenge and a resulting surprise in the diagnosis at the end. Starts with our patient's first presentation in July last year. He was a 56-year-old man who developed recurrent headaches and saw a neurologist privately. He had a past history of Wolff-Parkinson-White syndrome, but was otherwise quite well. He was working as a professional golf caddy, which involved a lot of international travel for quite long periods of time. He had an MRI as part of his investigation for the headaches, which showed a 12mm pituitary adenoma, not abutting the optic chiasm. He had pituitary bloods to investigate that. I don't have a thyroid result at that point, but otherwise it looked fairly normal. With a slightly raised prolactin, and his visual fields were normal. So at this point, the plan was to just rescan him in a few months and see how he goes. Over the next few months, while he was traveling, he noticed a postural dizziness. He was having to sit down, lie down very frequently. And then at one point, he was away in Saudi Arabia, and his whole team got food poisoning, and he was the most unwell and got admitted with a sodium of 110. Which improved with some fluids. When he returned to the UK, he was still feeling unwell. He had a bit of a collapse at home, came into A&E, still with a low sodium, 127. Had further pituitary bloods, and in the space of 3 months, he developed a low cortisol, low TSH and T4, unrecordable testosterone, and L8 and FSH. Still a slightly high prolactin. So he's basically lost 3 of his axes in the 3 months. His visual fields were still normal. He had a CT on admission, which just showed the mildly enlarged pituitary gland. The MRI looked like this as a T1 weighted image. It looked like it got bigger from the initial report, which was 12, and now it was 18 by 13.5 millimeters, with peripheral enhancement mostly. The findings didn't seem to be suggestive of hemorrhage or necrotic change, but there was a thickened area of enhancement over here, which was felt to represent a distorted and compressed infundibulum, and it was abutting the optic chiasm now. He was started on hormone replacement of hydrocortisone, thyroxine, and later testosterone, discussed again in pituitary MDT. I'm not really sure what this lesion was, possibly apoplexy in the past, which might explain his rapid deterioration in hormone deficiency, but no signs of acute bleeding. And he was planned for a surgical review to consider resection as it was getting bigger. He also mentioned thirst and polyuria. He had an overnight water deprivation test. So just had bloods in the morning. Sodium did go up a bit, but urine osmolality remained at 538. So just continued monitoring at this point. So yeah, in 3 months, we've just got this larger lesion, loss of 3 axes, and normal visual fields. Over the next few months, while traveling, he developed deterioration in his vision, which was fairly rapid. And when he came back, he had another visual field test, which had now started showing early bitemporal hemianopia, having been completely normal before. A few days later, he came in to Royal Surrey with fever, neck stiffness, photophobia, and headache. He actually attended one time. The symptoms improved rapidly. After a couple of days, he went home, but came back in again with the same symptoms a week later. He looked unwell. He was hot and sweaty. There was a rash that was maculopapular over his abdomen and back. There were no lymph nodes, but he seemed to have tender elbows and hands, like a reactive arthritis, and there was neck stiffness. It was hemodynamically stable, but there was a temperature of 37.9. It seemed to be a meningitic sort of presentation. He had an MRI fairly quickly on admission. Again, over a few months, there was more prominent enhancement of the right superior aspect of the lesion, and the whole lesion had got bigger. And there also seemed to be this possible impression of infiltration of the stalk extending upwards. And now the optic chiasm is mildly displaced, which would go with his visual fields. So this is all rapid change over 6 months now. He had every investigation ever because he had this meningitic picture, but his inflammatory markers were normal. He was tested for every infection because he'd been traveling all over the world. At that point, he was COVID negative. He also had an autoimmune screen, which was negative, CT chest and pelvis, which didn't show any hidden infection. He even had a PET CT, which only showed a little bit of something around the aorta, but given the negative autoimmune screen, this was thought to be not specific. This is his temperature during his admission. So initially he had this fever, and once he was started on ceftriaxone and hydrocortisone, it seemed to settle. But once they were stopped, it started spiking temperatures again. He did test COVID positive a few days into admission, which might have confused the temperature situation, but he didn't have any COVID symptoms and his inflammatory markers were still normal, so possibly not. Once he carried on spiking, he was restarted on the ceftriaxone and then acyclovir as well. The dose was even increased towards the 2nd week of treatment. And he had a lumbar puncture at this point as well. His lumbar puncture showed a raised white cell count, which was 48% lymphocytes, but all cultures were negative, virology was negative. It seemed to show a septic meningitis picture. He had another MRI 2 weeks into admission, and again, it's continuing to change. There's T1 images on the top, T2 on the bottom. And this right-sided change here in the stalk is looking a lot more prominent and has now also got this higher signal, T2 signal, on the right side of the gland, which wasn't there before. And he also noticed worsening thirst and polyuria. He was drinking 5 to 6 litres a day. He was getting up in the night. And again, did his blood tests early in the morning. His sodium had increased from 143 to 150, and urine osmolality remained low. So he was starting on desmopressin, and his symptoms did improve. So with all of these investigations during admission, he's now got an even bigger mass, loss of 3 anterior pituitary hormones and ADH, and abnormal visual fields. And we still didn't really know what this was. It didn't look like a typical adenoma. It didn't look like apoplexy or bleeding or abscess or anything we could really work out given his meningitic presentation as well. So he was transferred for transsphenoidal resection and biopsy. A lovely video of what it looked like. It was also unusual. I think he had a tough capsule and then this kind of easy substance inside. So it was therefore very important we had some histology. Post-op, the lesion appeared to be removed, but there was some residual enhancement at the margins around the infundibulum. And this was his histology, and I'd really appreciate some explanation from my histology experts.
Yeah, thank you. So from pathology point of view, as you will soon see, this is quite straightforward case. So we have this lesional tissue. If we focus here first on the blue square, which is shown here, that's just normal anterior pituitary tissue. It has this sort of preserved lobular cytoarchitecture. And then we have areas like here. There is another one, but I've zoomed in on this specific area where again you can see there's a florid epithelial proliferation which has this squamous appearance, so we do not see anywhere wet keratin. The epithelium hasn't got that stellate sort of rarified appearance. It's just sort of a multi-layered squamous epithelium. And with this one, the differential really would be between heavily metaplastic Rutke's cleft cyst or papillary craniopharyngioma. And here, mutation-specific antibody, the BRV 600D, shows this cytoplasmic labeling in the epithelial cells, which makes it by default papillary craniopharyngioma.
So that was quite a surprise for us because I don't think we'd even really considered that as a diagnosis before the histology came up. So papillary craniopharyngioma, and the continued management was with hydrocortisone, levothyroxine, and testosterone replacement. His IGF-1 is normal, although it is drifting down. So in summary, this patient had a rapid progression of his condition with growth of pituitary lesion, so we thought, a visual field defect, anterior pituitary hormone deficiency and ADH deficiency with an unusual radiological appearance and presentation with aseptic meningitis, all due to craniopharyngioma. And so our questions are, is further treatment with radiotherapy required for this patient? You need a show of hands or... and should development of aseptic meningitis increase suspicion of underlying craniopharyngioma?
Thank you very much. Wow, there's two cases in a row where the radiology and the histology look not concordant. So I think we just have to explore what's going on. Aseptic, what's the second question? Should development of aseptic meningitis increase suspicion of underlying craniopharyngioma? Does anyone want to take that on?
Can I just ask about the white count? It was a very high polymorph count for aseptic meningitis. I mean, could it have been a leak and maybe he got a real infection?
I imagine that you might be, I mean, he also had a temperature.
Yeah, I had COVID. So
But temperatures after, so that, do you think two things may be going? So do we think that the cyst was leaking and causing a chemical meningitis, and you're proposing an infection as well?
So the Staph aureus goes up the nose or through the hole, potentially? I mean, look at the polymorphs, 52%, that's a lot of polymorphs, isn't it, for aseptic meningitis?
you can get abnormal CSF with apoplexy, can't you, for example? I mean, it didn't grow anything, did it? But it had antibiotics. I don't know if it's...
Who did the surgery? Was it...
I think it was me, wasn't it? Because I don't know how you got that video from, because I showed it in the meeting and maybe you copied.
From Prof. Russell Jones.
Well done. It was on when your WhatsApp chat.
Because you were wondering if it was an abscess at one stage.
I was about to say that,
weren't you? The appearance was quite yellowish, purulent stuff coming out as soon as I incised the dura. And craniopharyngioma was not in the first preferential diagnosis in that case, but I thought maybe a necrotic pituitary tumor, and second possibility was an abscess, but it wasn't an abscess.
Do we want Emma to comment on the radiology? But it's interesting.
And that's a bit,
Microphone. And while it's going there, there's a question about, do you have a KI67 result? Would that be useful?
didn't see it in the report.
That's not part of the cranio histology, I don't think.
Do you mind putting the slide back up from the... So I remember this case from the MDT. No, we didn't think it was a papillary craniopharyngioma.
No, sorry, wrong way.
Yeah.
That one good?
I mean, knowing that histology is the only way we can interpret it differently, no?
But not always. Yes, thanks. That's perfect. So yes, very typical for a papillary craniopharyngioma, which we usually expect to be more centered in the suprasellar region. They can have cystic components, but they're classically more solid as opposed to the adamantimonious. Can't pronounce it. So it is unusual in that aspect, and also you can see that it was rapidly evolving, and I don't know whether we saw some areas, but there were some increasing little nodular components in the thickened infundibulum that were growing and evolving fairly rapidly. So our working diagnoses at the time during the MDT was an adenoma or something a little bit more concerning, like a glioma, for example, because it was evolving so rapidly, or a pituitary abscess, a necrotic hypophysitis. We had lots of other ideas, but none of them were, unfortunately, papillary craniopharyngioma. So humbled, yeah.
It'd be nice to tie it together and be able to say that the one thing triggered a second reaction or something, but I am slightly struggling. Is anyone else?
There's a comment here. Was a full 6-week TB culture negative?
Yeah. I have written down
There
here
was
queried.
1%.
His protein was up. I can't remember how low his glucose was, but there's always that worry that the TB is a great mimicker, isn't it, of everything?
2.6 glucose was.
There's nothing histologically.
Yeah.
Nothing granulomatous on histology.
Okay, thank you.
I know, that's why I asked about what it looked like as well. Okay, would that, can we explain his full absolutely pan hypopituitarism from the histology versus the radiology fits with that really, doesn't it? The histology is still slightly difficult.
Presumably think there's destruction though, don't we, in terms of destruction and...
You don't see what the adenomas with these unusual things we do. Was the procalcitonin done? Someone's asking here. Ryan.
I don't know if he had a procalcitonin done when he was
test it anymore.
It can be helpful, can't it, for bacterial infection? Any other questions from the floor? Thoughts or comments?
It's bacterial PCR on the CSF is another thing that
It's negative.
was negative. Thank you.
Oh, Agni, yes, sorry, it's your case.
It was an abscess.
Yeah, we thought it was an abscess, but
it's not possible that we missed
so
something.
we thought it was an abscess, and that's why we were pushing for surgery. And when we got the video, of course, you know, Prof sent it to everyone and saying, look, it's goo coming. So we were very, very surprised with the histology.
Do you think it could be both then? And we missed the infection bit if it didn't go in a micro pot or something.
I mean, we were looking for it. We were checking everything. I mean, the CSF didn't grow anything. There was, I mean, on the microscopy, there was no. So I think and the TB everything was negative. I mean, we checked for everything. Interestingly, should I say or not, IgG4 was mildly elevated. We even checked that. But I think we discussed with you guys and you said, just ignore.
So how long is it since he's had his surgery and is he better? I suppose that's the main thing.
So I think the question is about the radiotherapy. So he is currently having his radiotherapy not as we speak, I don't know at this moment, but yes, he's started radiotherapy. Yeah.
Patients will go for radiotherapy for papillary especially, so they have a higher rate of recurrence. In this case, it's mainly...
Maybe do a microphone.
In this case, it was mainly a drainage of the whole cystic and necrotic tissue rather than an excision of the whole tumor, primarily because it's all near the infundibulum and the third ventricular floor. So he would have had some residual tissue which would need radiotherapy.
I have one question. Why do we think it has grown so quickly? Because it's been literally 6 months. What made it grow so quickly? Because it was kind of something that probably was there for some time. And
I'm not sure it was actually the growth of the solid tissue. The cyst definitely expanded, which is possible with this craniopharyngiomas.
yes, that's true. I guess
Yeah.
those
So is it the
cystic
cystic
lesions can
component
wax
that
away.
fills up
can't they?
with fluid? and
We
then
do
looks
see
suddenly bigger?
cysts fluctuating quite a lot, but I agree. You sort of wonder if there was another component that we haven't quite nailed. I would definitely be interested to follow him up and see what's happening, which you're going to, I know.
And the question about the aseptic meningitis was really because there's been a few reports of this happening with craniopharyngiomas,
Yes,
with cysts, and mostly post-op, I think. But
release of the fluid going in and causing a reaction.
should that have made us think of it?
COVID, he was COVID positive.
Yeah.
But can he cause similar sort of feverish symptoms and sort of meningism? I don't know, medically.
It definitely causes a temperature. Other than that, maybe COVID mimics everything, but I haven't diagnosed a COVID meningitis myself, but we're slightly struggling there, but I take your point. Thank you. I understand. I think the fever was there. I don't know whether you get that with an aseptic meningitis. I'd love someone to tell me it all makes sense, but I'm still struggling. But I think it's a fascinating case, and thank you very, very much.
I would like to introduce Dr. Mon with a very rare case of TSH secreting pituitary adenoma, and she's from West Middlesex University Hospital.
Is it the revised? I've got two. Here's the revised one. Sorry.
Good afternoon, everyone. I'm Lam Yan Mon, one of the senior clinical fellows from Diabetes and Endocrinology Department from West Middlesex Hospital. Today, I'll be discussing about one of a very rare case of TSH secreting pituitary adenoma. This is about a 38-year-old lady who was referred to the endocrinology clinic for asymptomatic thyroid dysfunction with normal TSH of 4.5, raised free T4 of 22.5, raised free T3 of 8.3. With a past medical history of obesity, impaired glucose tolerance, gestational diabetes in both pregnancies. With a family history in her sister having thyroid dysfunction in her childhood. She has completed her family and her menstrual cycle is regular without galactorrhea. On examination, clinically euthyroid, and there is no discernible goiter without visual field defect. We repeat the thyroid function test, which still show TSH of 5, free T3 of 7.4, free T4 of 19, which are all again raised. To exclude assay interference, we did a paired assays with Simon and Roche, which showed concordant results. And we did the pituitary axis. All the pituitary hormonal profile are preserved. So we did the MRI pituitary, which showed 10 millimeter pituitary macroadenoma without Mars effect on the optic pathways. No lateral extension. So at this point, the questions come up, what is the diagnosis? There will be a poll that you can give the answer of your choice.
Yeah, you can read those out for
Yeah. A TSH secreting pituitary adenoma, B, thyroid hormone resistance, C, all of the above, D, not sure.
I like the not sure. That was nice.
It will be your answer of choice, maybe. Thank you. A TSH secreting pituitary adenoma, which is the topic. And, and maybe quite early. And B, thyroid hormone resistance. C, all of the above. And D, not sure, which is tempting.
Okay, I think that's very particularly, so well done, everybody. We can possibly. Oh, very appropriate. Yeah. Let's get out of this now for a minute.
So at this point, we're seeing obviously MRI is showing pituitary macroadenoma. Is it a case of TSH secreting pituitary adenoma with the incidence of 1 in 1 million? And bearing in mind that in her childhood, her sister was diagnosed with thyroid dysfunction in association with low BMI, which was already resolved spontaneously. So can it be a case of thyroid hormone resistance? And again, putting the thyroid function test, MRI findings, and family history all together, can it be a case of thyroid hormone resistance coexisting with non-functioning pituitary adenoma? What should we do next? Are the answers A, B, C, D, E. There will be a poll that you can choose on of your choice. A, repeat the MRI pituitary because it is not convincing. B, TRH test. C, repeat prolactin. D, serum alpha subunit. E, not sure. Whether we're going to do MRI, whether we're going to do the blood test, just let it be not sure. The tempting one is alpha subunit.
And TRH test, I guess.
And TRH test. So what have we done? Let's have a look on the flowchart for the differential diagnosis between the TSH tumour and thyroid hormone resistance. It has been from 2013 TSH tumour guideline from the European Thyroid Association. We can see a lovely diagram, and we can see all the tests that we can do for TSH tumour and thyroid hormone resistance. But the interesting one is only the TRH test is showing both solid lines projecting towards both disease, thyroid hormone resistance and TSH tumour, showing the solid lines indicating a stronger diagnostic indication as per 2013 European Thyroid Association and the journal. And why not alpha subunit? Alpha subunit can be produced from the pituitary adenoma, isn't it? Why didn't we choose that? Alpha subunit can be produced from TSH pituitary adenoma, yes, but it can also be produced from non-functioning pituitary adenoma, that's what we are trying to differentiate. In that case, we try to do the TRH test rather, which would be an autonomous function production. So we did the TRH test, which showed TSH 4.2, 4.2, 4.1 at the baseline, 20 minutes and 60 minutes, respectively, with a flat response. Of course, why didn't we do the genetic test right away? Bearing in mind that even if the genetic test is negative, there is still 15% chance of having thyroid hormone resistance genetically, because the site of mutation is being unclear so far. So now we've got the diagnosis with our topic, TSH secreting pituitary adenoma. Questions for discussion here. Would you conduct the diagnostic evaluation differently in this interesting case. Question 2, could she be a good candidate for elective transsphenoidal surgery given the MRI finding? Thank you so much for your kind attention.
Do you want to comment, Ramesh?
Yeah, thank you. That looks like a very defined target, quite away from the cavernous sinus, so it should be fairly a reasonable surgical target for a surgical approach.
Thank you so much for your kind comments.
Thank you. Were you contemplating any medical therapies?
Yes, so before the surgery, prior medical therapy would be helpful in shrinking the tumor, we believe. So we are planning for 20 milligram monthly medical therapy first before diving into the surgery, after getting the opinion from the surgery team, of course.
Thank you. Any questions? Yes, Alison.
All my flat shoes on purpose. Hi, thank you. It's a really interesting case. I wonder actually if these are a little bit less rare than we've previously thought. I have a case very similar to this, who I met first when she was pregnant. I've now seen her through 3 pregnancies. And it's behaved in a very indolent fashion, and her TSH and her free T4 and her free T3 have tended to be just at or just above the upper limit of normal. They've gone up and down. And I've discussed her at the Pituitary MDTM with Mark Ganell at Cambridge, and I think he's collecting quite a few of these now, these sort of very indolent, low-grade TSHomas which don't seem to progress. I think I'd have worked her out very similarly, although I might have done an SHBG a bit earlier, because that's often helpful. I just wonder if anyone else has got more of these lurking somewhere that's more than we think of in the literature.
Alison, has that case been managed medically, or?
Repeat that on the microphone.
Oh, sorry.
We were holding sort of somatostatin manipulation in reserve, but she's not really needed it. And your patient's well. I mean, it just sounds like it was a coincidental finding. She's not clinically thyrotoxic. And if there's no tachycardia or reduced bone mineral density and they're well, you know, my patient hadn't completed her family, and we didn't really want to go into her pituitary until she had, and she's actually remained so well, she's keen to just do nothing for now.
Good point, isn't it? And I guess even somatostatin analogues, if you want a pregnancy, aren't indicated either. So you're a bit stuck, and it sounds like a interesting, conservatively managed case.
Anything else?
Karim, anything on the chat?
Not really. I just looking at that scan. I think it's nice to demonstrate the fact that surgeons like nice round targets that don't invade the cavernous sinus, and that's a very important discussion at the MDT. Because if it was invading sideways, then I think you'd be less keen to operate. If there's a nice target, then that changes your differential options of treatment. Because we have got some patients who are quite toxic who've been on lanreotide for a long time, and there are others who go for surgery.
That I've had a similar case with the extensive cavernous sinus involvement, which we were able to remove from the cavernous sinus. So it's not a contraindication for surgery. But
right. Okay, well, that's very
and we've had some patients not tolerate octreotide, and some that definitely aren't suitable for surgery. So I think it's just individualized management depending on all of those factors. But thank you very much once again for a lovely presented case.
Thank you so much.
We now introduce Dr. Hyams, who has a very rare macroadenoma mimic. And Dr. Hyams is here at Imperial.
Thank you. This is our last case, I think. So just remember to do your feedback at the end. I think we'll put it up again at the end. So and make sure you've got that. Thank you very much.
So hello, my name's Lizzie. I'm one of the ST5 trainees here in Northwest London, and I'm just presenting a case, a lady who first presented in 2018 to Charing Cross Hospital. So our patient is a 30-year-old woman who was 36 weeks pregnant, and she presented with a 5-week history of headache, vomiting, and visual disturbance. She had a past medical history of migraines, and this was of a different nature, sciatica, and 8 years previously she'd had an uncomplicated pregnancy. She was on no regular medications, and she was independent, living with her family. Her father did have a diagnosis, she believes, of a pituitary mass which needed 2 surgical procedures and post-operative radiotherapy. She was hemodynamically stable and she had no neurological features. And she'd actually been seen by an optician the day before and was reported to have normal visual fields. Her bloods were overall unremarkable apart from mildly elevated white cells and neutrophils, and she had an elevated alkaline phosphatase, which you'd expect in pregnancy. And the differential diagnosis was, is this a recurrence of her migraines or was this a venous sinus thrombosis? And she had an MRI brain. This showed an intracellular lesion which was enlarging the pituitary cella. It was seen to contact the chiasm, but there was no overt compression, and it was thought to be suggestive of a pituitary macroadenoma. The patient was discussed with endocrinology, who advised just check the 9 AM cortisol and the thyroid function, and if that was normal, she could be discharged. So here are her bloods at that time. She had a 9 AM cortisol, which was within the range, although we should note that as she was pregnant, her cortisol binding globulin would have also been high. Her prolactin was elevated as expected, and her TSH and thyroid 3T4 was normal. She was discharged, and then 3 days later, she gave birth. She was overall well. She had a mildly high blood pressure after delivery, which self-resolved, and the baby was just slightly small for gestational age. She was discussed in pituitary MDT a week later, and the impression was the diagnosis of macroadenoma presenting in pregnancy with contacting the chiasm. The plan was to review her in clinic with a 9 AM pituitary profile. A question was put to the MDT, could she breastfeed? And it was advised she could. She would need formal visual fields in 6 months' time and a dedicated pituitary MRI in a year after she stopped breastfeeding. Before she could be seen in clinic, she presented 3 days after delivery with a worsening headache, loss of vision, and word-finding difficulty. Again, she was hemodynamically stable and there was no focal neurology. Her bloods were overall unremarkable. This time she was admitted and she had a dedicated pituitary MRI. This was reported as showing an increase in the size of the suprasellar component of the suspected macroadenoma, stretching the chiasm, but with no evidence of hemorrhage. This was her pituitary profile 5 days after giving birth. So she had a 9 AM cortisol that was low. She had a low free T4 and an elevated prolactin, and she was breastfeeding, but overall, otherwise not particularly abnormal. And she was found on formal visual field assessment to have a mild left-sided visual field defect. So I'll ask the audience now, what would you want to do next for this lady? Would you organise a short synaptin and review her in clinic? Would you want to do an insulin tolerance test and review her again with the results? At this point, would you start 3 milligrams of prednisolone? Would you start 60 milligrams of prednisolone? Would you only start 50 micrograms of levothyroxine? Or would you start prednisolone 3 milligrams and then 50 micrograms of levothyroxine?
Sorry, I hit the wrong button. Resume share?
Yeah.
Sorry, I hit the wrong thing completely. Sorry. Let me just. This is the last case, so try and give it your all. We'll just give a couple of seconds to try and get a few more votes and we'll have a look.
When did she present with how far after the delivery was this presentation?
3 days after delivery.
3 days after
About
delivery.
a week after having her first pituitary, her first MRI that showed the macroadenoma.
And so significant change in size.
That was the report. Yeah.
So.
Oh, I'm so sorry. I'm doing well here.
So has everyone had a go at logging on.
Okay.
So the majority of you would like to start prednisone followed by thyroxine. I think that's but some people would like an SST. I guess it's quite a split, isn't it?
Okay, so yes, that's exactly what happened. She was started on prednisolone, and then she was seen in clinic a week later. She was well, and levothyroxine was started, and there was just a plan for regular follow-up and repeat the pituitary profile and, visual fields. So then we go to about 6 months later. Clinically, she's well. She's still on prednisolone 3 milligrams and levothyroxine. She continues to breastfeed. She reports ongoing left-sided headaches and left-sided visual disturbance, and she's under regular ophthalmology review with an ongoing visual field defect. Because of the history with her father, AIP mutation testing was sent, which was negative, and the working diagnosis is a pituitary macroadenoma with secondary hypothyroidism and hypoadrenalism. Her bloods at 6 months show the thyroid hormone within range, and she's on levothyroxine, a mildly elevated prolactin, but otherwise no significant abnormalities. We now skip forward, we're still at 6 months, and this is the first pituitary MRI that shows there is a decrease in the size of the lesion, and it no longer elevates the chiasm. So a year later, she stopped breastfeeding and she has an insulin tolerance test, and that shows that she has an inadequate response, and so the plan is to remain on steroid replacement. In terms of her thyroid hormone, 2.5 years after presentation, when she just reported in clinic she'd stopped taking levothyroxine, her bloods were normal in terms of her thyroid function, and they've remained normal ever since. She also reported in clinic that intermittently, quite often, she forgot to take her dose of prednisolone, and that was in her appointment 4.5 years later. So she did have a short synaptin, and that actually showed an inadequate rise in cortisol, so she remains on prednisolone 3 milligrams. In terms of her visual fields, so you can see there was a mild left-sided deficit at diagnosis. At 6 months towards 8 months, she then reports worsening symptoms, and you can see that she's got bilateral visual field abnormalities. We acknowledge that these would not be what you'd expect with her disease, but she remained under regular ophthalmological review, and they've spontaneously resolved. And then finally, in terms of her imaging, the most recent MRI was done 4.5 years later, and that shows there's no evidence anymore of the lesion on her MRI. So at this point, I'd like to ask again, it's our last question, I think, of the whole day. What would we like to consider? Do we think this is a pituitary adenoma with spontaneous involution? Could it be pituitary apoplexy? Is this a primary lymphocytic hypophysitis? Is it an IgG4 related hypophysitis? Or could this have been Sheehan syndrome?
Jeremy's got a question. Oh, you need a microphone. Everyone log on and do the last vote of the day.
Sorry to ask, but what happened to her periods?
I think she was, when I've been speaking, she's having regular periods at the moment. I can't remember exactly when the clinic letters they restart, but she's now having regular periods.
Okay, 6:50. Oh, okay, that's quite a solid vote, I think, isn't it? Okay, so everyone, well, not everyone, but the majority have plumped for lymphocytic hypophysitis.
Okay, so just to recap, we had a lady presenting in the last trimester of pregnancy with a headache. She has a pituitary MRI that has shown a stellar mass that spontaneously resolved, and her hormone deficiency was isolated to ACTH and TSH, which is now resolved. And so the temporal relationship with pregnancy, the pattern of hormone deficiency, and the spontaneous resolution has led to a new proposed diagnosis of primary lymphocytic hypophysitis. She's well, she is having regular periods, and she would like to have another child. And so our questions to the MDT is this, or could this be lymphocytic hypocytis? And it seems like quite a lot of people think it could be. Would there have been any role for high-dose steroids in the acute phase? Does she need a surveillance pituitary MRI? Her last one was done 4.5 years after she presented. And what would we advise for any future pregnancies?
Thank you very much. Would anyone like to have a go at any of those questions? I think Florian, she's your patient, is she? Ah.
With Alison.
Who's, ah. Very sensible questions.
Was it, did you say Alison? Yes, I'm handing Alison the microphone. Yes, with your OBSMed hat on, Alison.
So the question was, just sort of for the audience out there, there's 100 people out there.
You do an antenatal clinic.
With her choice, aren't you?
Here with the microphone on, because
she wants a further child, and I mean, she's done all right last time. She, you know, with awareness of it this time and the potential for relapse, it could happen again, but at least, you know, forewarned is forearmed, and you know, if she can have herself monitored, I don't see any reason why she would.
So there's a question here for Alison from the audience, and it says, although normal, the T4 is a little bit low, would you give her thyroxine during the pregnancy? It was 9, wasn't it?
Yeah. We see her, I mean, it was right at
9 to 23. This one.
No.
Presenting one.
Well, the stage of pregnancy that she was diagnosed, the fetus is entirely independent of maternal thyroxine. It starts making thyroxine at 14 weeks and is independent by about 20. And I think there is evidence definitely to treat isolated hypothyroxanemia in early pregnancy when the fetus is dependent on mum.
That's a good point. So
in summary, yes, for early pregnancy.
So you're saying, Alison, that because this is late pregnancy, yes, you would be very happy with that thyroid function, not necessarily needing any thyroxine replacement.
So physiologically, T4 falls. Physiologically, T4 falls in late pregnancy. So our late pregnancy lower limit that we use is down to about 8. You know, that's a physiological change. So, I mean, in this case, it probably wasn't. It probably was secondary hypothyroidism, but the baby's making their own T4 at that stage.
But in this one, the 9 is 5 years. Yeah, so this is not pregnant.
No, this is the most recent.
I think there's just a few questions. One is how to manage a subsequent pregnancy. I think that's a general question. For any further advice on that, and what degree of monitoring? Is that right, Florian? And any imaging before a pregnancy? That was another of your questions.
Yeah.
Sorry, Neve, I'm aware that we discussed this case at the Pituitary MDT multiple times, and I just wonder what a radiologist thought about the initial presentation, if I may put you on the spot, please.
Yeah, I looked for him and then I couldn't. It's not
just get her imaging up.
Listen, can you put the imaging up? Because I was hoping, poor Emma, you're not going to come again, are you? But we've loved having you because you told us so many exciting things about the radiology. It's, the question is it? Is it? Okay.
We've got several images, haven't we?
It's regressed.
Okay.
Over time, we're wondering if it wasn't.
And is this at 6 months?
Yes.
What's the timing of this in
I
relation
want to go back and show the other ones.
So this was the first pituitary MRI, which was done, when she was pregnant. And this is the one that was reported as being a bit larger.
Yeah. Okay. So you can see that there's sort of an ovoid with tubular enhancement of what looks like the adenohypophysis, and without being able to see close up, it looks like we still have a posterior pituitary bright spot there rather than a thickened dorsum cello. So again, that would go against hypophysitis. But actually, if you look at the top, it looks like the stalk is thickened. It looks like it's foreshortened, but also thickened throughout its course. So it does look it looks convincing for hypophysitis, lymphocytic hypophysitis in the context of pregnancy. I'd expect if I had post-contrast, it would be homogeneously enhancing. On the later image that you showed me, it did look like it was homogeneously enhancing. It would be odd for an adenoma to be hyper-enhancing relative to normal pituitary. So to me, it looks like a
inflammatory hypophysitis.
That's really helpful.
Lauren, just out of curiosity, because I'm really sorry, I can't remember. We must have discussed query lymphocytic hypophysitis if she presented in pregnancy in the MDT. What made us plump for an adenoma? Or was it just that was the differential?
I think that at the time, the overall feeling was that we couldn't exclude an adenoma, and it would more likely be an adenoma, the whole presentation. But actually, I met her much later on in clinic. And when she then started stopping her penicillin and the thyroid function recovered, and her pituitary scan completely normalized. And I couldn't really think of, and I still cannot think of an alternative diagnosis.
That's really interesting. And again, I think as a sort of take-home message is always challenge yourself when the radiology and the history don't quite fit, and work out the middle path, which probably it seems to be very likely to me the way it's been presented today, but maybe at the time one doesn't quite see it like that. I certainly remember a case that we admitted and had visual problems and went to surgery, and I can't remember exactly the circumstances, but it came back as hypophysitis, and it hadn't been even thought of before because it looked so cottage loaf shaped adenoma or whatever. So I think it's just always worth just challenging yourself in these slightly tricky cases.
Yeah, I remember the case also. There is a disproportionate visual findings with these sort of cases. You don't see that much of a chiasmal compromise, but you see abnormal visual fields, not typically bitemporal. It could be an arcuate or it could be a bilateral kind of pathology on the visual field.
Yeah, I think that's a really good point, Ramesh. Okay, I think that was a lovely last case. Thank you very much.
Just doing it. Okay, so thank you very much for to all of our chairs, particularly our chairs of the last session and our chairs this morning before lunch. Thank you for all the wonderful speakers and your wonderful talks. It's been a great day. I've learned a lot actually, and I hope you all have. And just a reminder that if you can give us some feedback, we'd be really grateful just in terms of how we can make this better the next time. And actually a thank you to Emma Lim, who has provided lots of neuroradiology, which I've been really grateful for actually, because sometimes we really struggle to interpret that ourselves for obvious reasons. So yes, thank you very much. Safe journey home. I think some of the trainees are having a meeting downstairs where you can help yourself to any residual refreshments, please, so we don't have to take it all home. And then, as I say, thank you to everyone for their participation, both remotely and in person. We've really enjoyed having you, and we've really enjoyed all your lovely questions. So thank you very much and goodbye.